That's okay. Okay, next slide, Daniel, thanks. So diabetes is what we call a chronic condition. And that means that that means that there is no cure. And sometimes we read about the fact that diabetes can be cured, but this isn't the case. The causes of diabetes in terms of type 2 diabetes primarily lifestyle, where often you have to have a family inherited risk. So somebody in the family already has diabetes, and that means that it's passed on from generation to generation. That certainly means that what we call predisposes you to a higher risk of developing diabetes. But on top of that, if you don't get enough exercise or if you become overweight, those things can actually become a trigger to the diabetes actually developing. Also, you have a potential for there to be not enough insulin or insulin that doesn't work properly, and I'll explain that with a slide shortly. And there are some medications called steroids which also cause diabetes, and this is often used for other reasons. So it can be used to treat other serious illness, chest infections. It's sometimes used in the treatment of cancers in the process of giving chemotherapy. So there are all sorts of reasons why steroids are used, but this has a direct impact on blood sugar levels. And even if you don't have diabetes, you can actually develop what we call steroid-induced diabetes because of it. And it needs to be treated actively, so that sometimes in some people's cases, they may need insulin therapy to actually get good glucose or sugar control. So what happens when a person gets diabetes? Well, the blood sugar levels rise, and this can cause a passing of lots of urine. It can cause blurred vision. You get thirsty because you're passing a lot of urine, and also sometimes weight loss, depending on the type of diabetes that the person is developing. But one of the other things that's not as obvious is that people tend to be much more prone to getting infections, and they can also have poor healing of wounds. And if people are experiencing poor wound healing, it may be because their sugar levels are elevated, and this is one of the triggers and causes of the wound not healing properly. And we'll talk more about that later. Next slide, Daniel. So this is what somebody with diabetes might look like. These are the issues around what a person with diabetes may look like. So they are always tired because the sugar is sitting in the bloodstream and not getting into the cells where it's used for energy. So people with diabetes or developing diabetes and high sugar levels can often feel very tired and lethargic and can't be bothered doing anything because they just haven't got the energy. Blurred vision occurs as a result of the sugar that sits in part of the eye, and that causes people to have blurred vision. It will recover as the sugar levels improve. These things recover spontaneously or immediately over a few weeks, but it can be caused by the sugar itself. Strangely enough, that when there's so much sugar sitting in the bloodstream, sometimes people can feel hungry. And this is because that sugar is sitting in the bloodstream and not in the cells where it's burnt for energy. And so people get a sense of being hungry because those cells are starving in the midst of plenty, we sometimes say. So it can be not a common symptom, but it certainly can be something to think about. They're always thirsty. I mentioned that earlier because the body is trying to normalise the sugar, and it passes a lot of urine, makes a lot of fluid, takes a lot of fluid out of the body, and so that creates thirst. Sudden weight loss can occur, particularly in type 1 diabetes, and so we talk a little bit about that shortly. I already mentioned passing a lot of urine and frequently, wounds that won't heal, and sometimes the other things that I didn't mention earlier are numb or tingling hands or feet because the nerves don't like to sit in all that sugar. And sometimes people can have sexual problems where men can't get an erection, women can't have, they find sex difficult because of the circumstances of their glucose. So it can be very difficult, and it covers a whole cross-section of symptoms and possible silent or less obvious triggers to the onset of diabetes or the causes of diabetes. Next slide, please, Daniel. So let's look at this slide in a bit more detail. And I don't want you to worry about some of the terminology in here because you may not be familiar with it. And it's a complex slide potentially, but I'll simplify it for you. So what happens is that when we eat food, that's broken down and it gets developed and broken down into glucose. simplest form of carbohydrate. Now, that glucose will sit in the bloodstream unless enough insulin is produced, and unless there is insulin there in the first place, and unless it's released. And then what it does is, if you'll notice that it attaches to these little blue things called insulin receptors. They attract insulin, which are the little triangular sort of symbols there. They attract insulin to, excuse me a minute, they attract insulin to these little receptors. And when those insulin little triangles and the receptors actually connect together, the cell wall opens up and glucose passes across into it. Now, that's very simplistic, but that's essentially what happens. And there are other mechanisms in that slide that I won't worry you about at the moment, but there are things that allow that glucose to pass across into the cell, and that means then that it comes out of the bloodstream and the blood glucose settle or remain normalised. So when those little triangles called insulin attach to the little blue receptors, then the cell wall can take up glucose and the cell functions, and you have energy, or the person with diabetes has energy, and and everything operates normally. Okay. When that doesn't happen, when those little triangles don't attach to those insulin receptors, then the glucose builds up in the bloodstream. And so the reasons why those insulin little triangles don't connect to the receptors is because it's like a lock and key, if you like. When they fit together, it's great. When they don't, it's a problem. So they either don't fit together because, one, there's no insulin there, like there isn't in type 1 diabetes, or that triangle and that little receptor, they can't lock together because there's something wrong with that lock and key. So the insulin might be there, but it just can't function and connect to that receptor. It's really more about trying to understand that physiology. And it is difficult, but if I'll try and explain it differently if that's a problem for you. But we'll move on to the next slide. Are there any questions about that though first? Okay, next slide, Daniel. So there are many types of diabetes, and the main ones are, first of all, a type of diabetes. Well, we actually call it part of the classification for diabetes, and it's called impaired glucose tolerance. And this is where the glucose levels are not high enough to be in the diabetes range, but they're higher than what we would say the normal range is. And the issue around diagnosing impaired glucose tolerance, excuse me a minute, I'll ring you back, I'm doing a lecture. Sorry about that, everyone. The reason why we actually concentrate on impaired glucose tolerance is because a lot of people have high blood sugar, but they also have high blood pressure and they also have high cholesterol. And the three of these things together can put people at a very high risk of developing cardiovascular complications, heart attack, stroke being the primary ones. So we like to diagnose people and treat people with impaired glucose tolerance, because there's also a high chance of people with this developing and progressing on to develop type 2 diabetes. Okay, so about 2/3 of the people who develop impaired glucose tolerance will actually get type 2. Then we have type 1 diabetes, which is an autoimmune condition, generally occurs in young people, children and young adults, but can also develop in later life in adults. And we see a lot of it in this country. About 20% of all people diagnosed with what we think is type 2 diabetes have this less obvious what we call latent or silent onset of this type of type 1 diabetes, where the antibodies that destroy the insulin producing cells are active, and eventually they will become properly type 1. So there are different types of type 1 these days, and it's more recently only been described in the last probably 15 years, 20 years probably. So it's a more new version of type 1, but we do know that it occurs right across the age spectrum now, whereas we used to think that type 1 diabetes was called juvenile onset diabetes because it only occurred in young people. Now we know that type 1 diabetes can occur in a variety of ways across the whole age spectrum, from baby right up into people who are in their 80s and later. So it is changing very much about type 1 diabetes, and it's important that you do and are familiar with the fact that it can occur at any age. Possibly not in your cultures, but certainly if you ever came to work in this country, you'd certainly see it here. Type 2 diabetes, of course, we've started to talk a little bit about that, and the fact that it is, again, primarily in both types of diabetes, actually, you should have an inherited risk. So there's someone in your family has generally had diabetes or has diabetes that you know of, a parent, a grandparent, an aunt, an uncle, a cousin. So these are all people in your family tree that you are part of, and that because of that, if they've got diabetes, then there's a chance that you may have inherited the risk of developing diabetes. Gestational diabetes is diabetes in pregnancy, and this is something that only occurs during pregnancy. It often finishes when the pregnancy is over and that the placenta has been delivered, and it's caused by a hormone called placental lactogen, and that occurs at about 26 to 28 weeks of gestation. And then we often test for it in this country. 100% of all pregnant women get checked for gestational diabetes at about 26 weeks of gestation on a glucose tolerance test. The glucose tolerance test is a different set of criteria to normal diabetes, to type 2 and type 1 diabetes. And the criteria for type 2 diabetes is a fasting of 7 or greater and a blood glucose 2 hours on a glucose tolerance test of 2 hours of 11.1 or greater. But in gestational diabetes, it's a fasting level of 5 and a 2-hour post-glucose load, a 75-gram glucose load of 8.5 or greater. So if the woman who's 26 weeks pregnant falls outside or into those categories, then they will have been diagnosed with gestational diabetes. And we won't talk too much about that today, but one of the reasons why in this country we actively diagnose gestational diabetes is for two primary reasons. One, because it helps to protect the baby, and before we used to do this, there was a high rate of fetal death in utero. And also because there are complications as a result of not diagnosing the woman with gestational diabetes. The baby grows big, it can be born prematurely. That creates another set of problems. And so we've now got a completely different approach to gestational diabetes. 50% of these women who are diagnosed with it will develop type 2 within 5 to 7 years. So there are lots of implications for both diagnosis in a clinical sense, but also to the person who's diagnosed with it, particularly where there's been a past history of big babies over 10 kilos. Over 10 kilos. Yeah, over 10 kilos. I just thought, oh, goodness, that's wrong. But yeah, so it's important that we diagnose gestational diabetes for a whole raft of reasons. Next slide, please. So one of the ways that we want to keep an eye on people's glucose levels or sugar levels is that we ask people in this country, and we encourage you to do it in yours, that they can actually check their own glucose or sugar levels on a regular basis. We have blood sugar machines that will take only 5 seconds to do. And I guess depending on where you are about the availability of these devices and these resources in your country, but we find that this is a very important part of self-care, and also making them financially accessible to people, either by giving them to them for nothing, this little strips that we use, or that they are significantly subsidised and that they then can afford to use and to buy these products so that they can then check their glucose level on a regular basis. It helps to ensure that the diabetes, their sugar levels are staying within target. And you might ask, well, what target do we set? Well, it's recommended that for everyone that they try and keep their sugar levels between 4 and 8.5 at the most. That's very hard to do sometimes, and it depends on a whole lot of other factors. But that's the target that we generally like to aim people for, because that's generally what we would consider to be what we call euglycemic, or within the normal range or the non-diabetic range or close to it. And that's really because we want them to have good long-term health. We want to have a whole raft of issues that may be contributing resolved, and this takes obviously a multidisciplinary team to achieve. It guides doctors in the management where they may see that sugar levels are still elevated. They may add or change medication to suit what's going on. So this gives the doctor, the treating doctor, an active guide as to whether the person with diabetes is actually achieving those targets or whether they need to actually change what they're doing. And everybody's different. So there may be a lot of people with the same diagnosis, but no two people will be the same unless they're twins, unless they're identical twins. It helps a person understand their diabetes better, and it also helps them see that if they make a food choice, whether all of that food choice was okay or whether it had a negative impact on their sugar levels. And this also then helps to train and teach that person that that choice may not have been as good as some other choices that they may have made. And so it in itself becomes an educational tool to not only the clinical treating team, but also to the person themselves. It detects early changes in diabetes. So if a person is checking their sugar levels regularly, they will pick up on a change to their sugar or their diabetes much quicker than we will, because we're not in their life every day. We come in and out of that life on a regular basis, but we're not living with it 24/7 like they are. And so this is really something that allows the person with diabetes to respond to early changes and to seek attention, or to seek, treatment if required, or to at least seek medical help, or from the nursing staff or whoever they see regularly as part of their diabetes care. Occasionally we can accept levels up to 10, and this is important to set a boundary about what we will accept. And then once people reach a point where we know we have to respond, it helps us to form a framework for intervention and to actively make changes to care. Thanks, Daniel. So why is this important? Well, it's important because when sugar levels are kept within the ideal range, or the target range we would call it, it means that the person's good health is maintained. It means that there's good long-term health and life expectancy, and we know this. The hard thing often is that we're putting these things into place. We want there to be long-term health, but it's not until people actually start to achieve that longer-term life expectancy that you see the benefit of what happened, say, 20 years ago. So it's very difficult sometimes to predict where you think this might head, but in fact, we know from experience and we know from research that when people achieve good sugar levels in the long term, we know that they have a better chance of a normal life expectancy and good long-term health, which helps to achieve that. If people have got a wound that requires active management, then this is going to be something that needs to be considered, and we'll talk about that later. But, good blood sugar control will actually help good wound healing, because it changes the environment of the wound and promotes wound healing itself. So that's an important consideration. Sometimes people come with a wound that won't heal and their sugar levels are found to be high, and this is really one of the things that you need to think about. So it reduces the chances of complications occurring in the kidneys, in the heart, in the blood vessels themselves, in the nerves, and of course in the back of the eye. And these are important major sort of areas where diabetes will impact if it's not well managed and actively managed in the long term. Daniel. So discussions and questions that I put, but I wondered if you've got any for me to answer from your own experience, if you'd like me to talk about anything.
I wonder if there's anyone that would like to share any current practice in their country about checking blood sugar levels, or if that's something that's not happening as often as perhaps it should be.
Hi,
Yes,
Jen.
Daniel.
Hey, Pratima and Alma, I think. Hello.
Okay, Fatima first. I'll go next.
No. Alma, you can go first.
Okay. Thanks for the presentation. So my question is, it's based around, like, for us, after after clients go through amputation and they come to the prosthetic service for a prosthetic limb, from their experience, from their appearance, the way they present themselves, we can see that their conditions are not good. But because we don't do the blood tests and all these, we can refer them to the right people to do that. But how can we advise them to, try and still try and maintain a good, like a good management system for themselves? Like, how do we help them out with that? Like, if I can notice that, their stump is not looking good, their appearance is not looking good, what's the best advice I can give to them?
It's very difficult, isn't it? I guess it's really important to try and understand what the barriers are and why they're not actually able to, why they're presenting so the way they are. I guess it's important to try and work out why that's happening. Are there self-care issues? Are they able to understand what they need to do? Have they ever been guided about it? I mean, they may not have ever been shown. So I suppose it's important to understand what the issues might be for them. And so that would be my first point. So what is the hardest thing for you about diabetes? If they've got diabetes, what is the hardest thing for you about your diabetes for you? Ask that question directly. Try and understand what might be an issue for them in regard to their self-care, and see if you can start to develop that rapport or that relationship that allows them to trust and tell you what's going on.
Thanks for that. Okay, now Pratima, it's your turn.
I have a question for Anne, just a clarification. And what is the unit measurement that you're using?
Oh,
For the blood glucose levels?
millimoles per litre. Sorry about that,
Okay, right.
everyone.
Yeah, thank you, because that's the unit we are using. And just to add on to the question that Elma had asked about, like for them, I understand that they don't do a screening when the patient, or a client presents to their department. But for our setup is very different. For every person who accesses our service, we routinely do their vital signs, which includes, their measurement of their blood pressure. We also do their random blood sugars on presentation.
Yeah.
And this happens during our clinic in the outpatient department based at the hospital, as well as during our outreach programs. We are able to pick up, the person's blood levels prior to the team attending to them. And we have noticed that a large number of our people who have been through all levels of health system still do have very uncontrolled sugar level. And then we have identified some factors, like they do not have access to regular, medication supplies. They, after suffering a disability or, amputation or stroke, whatever it is, it limits their physical activities. So that contributes to, rising blood sugar levels. Their diet changes because they are reliant on their family members and they are not able to access, the type of diet that should be, they should be consuming. So those are some of the factors that contribute to their sugars not being, knowing that these people have been through all levels of healthcare system.
Yeah.
My other team members are there on Zoom. If they have anything to add, they can add. Thank you, Anne.
Thank you, Padma. That is really important to know, because of course if they haven't got access to the medication for whatever reason, then it is very, very hard to heal the wound, to look after their well-being in the long term. And I think it's great that you do that assessment. That's a thorough way to bring them into the clinic, where you can actually have all the information at your disposal, if you like, at your fingertips, to actually then see what's going on at the one time, everything happening at once. I guess it's difficult to do anything if they can't get the medication. And I suppose my question back to you, all of you, is, so do you find that it's difficult to actually get the medication because it's not in the country, or is it because it's just that you're remote and it's hard to get that medication out to where you are? Or is it because the person hasn't accessed their medication and they just haven't taken it? So there's a lot of questions there, but I just wonder if you can respond.
Yeah, and I mean, you have mentioned some of the, reasons why the sugar is uncontrolled. So yes, of course, we do have, medications available in the country, which is available free of charge at the peripheral health centers, but from time to time, they run out of stock. So that's why I say, they don't have adequate access to, reliable source of medication. And then the other one, as I have said, when suffer disabilities, amputation, stroke, whatever it is, then they become dependent on the family members to go to the health facilities to get their medications. So if that does happen, the support is not there from the family. So, they don't get access to the medication that's available closer to their homes.
Yes.
And yeah, so those are the things I can remember. And the sugar levels, as I've said, like most of the families, they do not prepare special diets for these people. I mean, we capture only our target population. We don't, screen the general population. So I'm just talking about the target population that we, attend to. So they're very limited in what they can do and very dependent on the families to support them in the management of diabetes.
And so do the families, do they all participate in the education and awareness? Do they understand the importance of it, or are they separated and so they don't sort of have a good understanding of why that support is important? Do they come into the picture as well?
Yes, we have recently, not very recently, it's been a few months, we have a structured program here at our department for the outpatients who access our services. And we have got this counseling. So we talk about, everything that involves in there. So we talk to the person who accesses our services to receive, care, plus their family members and caregivers. So they are our target groups, and we speak to them, we counsel them, educate them, and we talk to them. And so for amputees who have been fitted with prosthesis, we do encourage them to take, their walks, in the afternoons or morning walks, just to burn that extra energy and, to develop that fitness that they need. So yeah, we put in the effort from our side, but then, as you know, the rest of the effort has to come from the client, their family members and their caregivers to maintain.
Yeah, absolutely. Absolutely. Thank you, Pratima. Are there any other questions, everyone?
Thanks, Pratima and Alma, for your questions. And if anyone else has any questions after the session, just send them through to myself and we'll send them on to Anne. And then we'll collate all the questions that we get from everyone. Would you like to go back to the discussion questions now, Anne? Or
well, if that's helpful, would people like to do that? I have some questions that I thought I put aside just in case people might like to respond. Would people like to do that, or do you have to go? Or
maybe give the thumbs up or say yes in the chat if you'd like to go through some discussion questions just to help understanding of diabetes and some initial diabetes management. We got one yes. I think that's 2 yeses. That's enough.
Okay, so this is a scenario that I put, and I guess it's something to just prompt your thinking. And we've already started to talk about some of these issues, and you've heard some of the things that Pratima and Alma are doing. But it's something that for you to think about wherever you are. So depending on where you are, to answer. So a person presents with type 2 diabetes and they have a wound with a glucose of 15, and they're currently taking the most tablets that they can take available to wherever they are in your country. So the maximum dose of tablets has been prescribed. What are your first thoughts, and what sort of considerations would you think might be worth thinking about? What would you think first? Any ideas? You can take some time to think about it. You can talk amongst yourselves and come up with an answer from all of you. You don't have to speak one-to-one.
Yeah, feel free to chat in the groups that you're in, guys, and come up with an answer.
And then we'll leave the slide up and you can basically talk about, you can go through each of those questions. You know, what are your first considerations? What options are available to you wherever you are and to this patient, and why is active management important in this situation?
We'll give everyone a couple of minutes, shall we, Anne?
Yes,
just
fine.
to discuss that with your groups or think about it individually, and then we'll come back and see if we have a few answers. No wrong answers, I would say, as well.
No. And if you're not sure, say so and we can talk it through, but I will respond to the questions, but you're going to tell me first. I'm not going to go in first. You're going to tell me what you think.
Oh dear.
Yeah, from Timothy. Hello.
Hello.
From Timothy Solomon Island.
Yeah.
Yeah. The first consideration, what we used to do is we ask the patient what usually they take, the normal doses they would take at home. So we will continue with the doses. If it's continue to be the same, then we'll continue to increase the doses. If it's taking 500 milligram metformin daily, then we increase it by BD, 500 BD, and then yeah. So the maximum doses would be like 1.5 grams TDS. But we are looking in the option of adding another anti-diabetic drugs like glibenclamide or glipizide, 5 milligram daily.
Yeah.
Yeah. So that would be the active measurement that here in Solomon, the Motu province would give. Thank you.
Thank you. Very good. Yeah. If you're on all that, if you're on, can I ask you, if you're on the maximum tablets they would take, would you start insulin? You try and get them to modify that.
Yeah, in my experience, I never give insulin to patients that is can be controlled. So it means that we can consult the consultant, medical consultant, to take their advice on cases like that. But for diabetic ones, with 15 millimoles on admission, we start giving insulin. There's what's the name they call it? We'll do isofin and afterpill together.
Yeah.
We would like isofin 10 units, and we slowly try to control a TDS of a BD, and then afterpill would be 5 units TDS. So it's kind of a regime that we use, and then we try to see where the sugar is, and then we increase or decrease from there until we control by the isofin, and then we'll give out the atropine, and then As when the wound is or infection is controlled, we'll start to give back the antibiotic oral. So yeah.
Very good.
Thank you.
Anybody else want to contribute? Thank you very much, Paul.
Yeah, and I think my Fiji team is there. I mean, we're in different places, but if there's anyone to add, they can add to for this particular, person to access our services with the glucose and the wound there. We would want to go through the whole process of, asking them questions of, whether they're taking their medications, how compliant are they with their medications, about their diet, and about their exercise level, because all these things, in the management of blood sugar. And then, as mentioned already, if the wound is infected with a glucose of 15 and the person is maximum dose of oral hypoglycemic agents, then of course we'll be very worried. In our setup here, we do not actually start our clients on the insulin straight away. We do refer them to their nearest health facility or the diabetes center that does further management of diabetes control. And then we leave it in their hands to provide further management, and then the person returns back to us for the services that they need with us. But we do give them counseling. So Shraddha, you were there. Is there anything you want to add?
Yeah, Strada's actually just put something in the chat a few minutes ago as well, Padma, and said similar to what you have said. And first, you want to check the wound and make sure it's not infected, and then second, check the diet of the patient. I'm not sure if you want to add to that, Strada.
They're not able to hear me. Hello, can you hear me?
Yeah.
Yeah.
Okay, it's same as what Dr. Pratima has said, that we'll take a history again as like full history, as the compliance of the patient, the diet, the check the wound if it's not infected, because that can be another factor which causing the sugar to increase.
Yeah, absolutely, absolutely. Well done, everyone. No, it's just really a good way to talk it out and make sure that, well, if you're not doing that, then it means that people are thinking through about what your options are. Everybody sounds like they've got very good structured processes to how you're actually going to move through this process with the person, and that means that you've got a process where you're going to have a plan, and you've got defined boundaries. Pranama, when would you start insulin?
Us here?
Yeah, when would you start insulin?
Shraddha, can you answer that? I do not start my clients here because we do not do the follow-ups. So we refer them to their nearest health facility or a diabetes management center where they get followed up. And they are the ones who adjust or change their medications and change to insulin and regulate it.
Yeah, sorry, I misunderstood you probably. Yeah, thank you. Thank you for that.
Yeah, thanks, Padma. And then, sorry, was that you, Shraddha?
Yes, that's correct. It's usually done in public health setting. So the doctors there, they'll be following up with all the blood results, and investigations will be done. And also they go through this diet plan with dietitian, and they actually have a home-based dietitian and community-based dietitian who goes home weekly, and then it's like a SNAP kind of program. And then from there, then the medical officer gets involved in it when the management of sugar level is not being controlled. So that's when they'll decide when to add to whether to change to insulin or to. Sometimes in Fiji we have also seen that with insulin they also put them on low dose of oral anti-diabetic medications, but it's not usually high dose of insulin, but low dose of insulin.
Okay, yeah, very good.
Also, it depends on certain times they cannot, they don't give them, they don't prescribe them insulin. The reason being because of the setting at home, they don't have the storage system that they for insulin. So it all goes back to what environment that particular patient setting is in. So it's a combined factors the medical officer have to see and then prescribe insulin or not insulin.
Well done.
Thanks, Shraddha. I'll just add in as well to further on Pratima's situation. We have also some P&O clinicians from Papua New Guinea on the call. And Lena has written in the chat, I'm not sure if you can see, but Lena has written, as a PO clinician, I won't directly deal with any medications. However, our inspector will refer them to consultation clinics for further medical attention. And if the wound is on the lower limb, we may be involved in making weight offloading boots or orthoses. Yeah, so just obviously that'll be the situation for many of the people on the call involved in the rehab side of things, and just assessing the wound and making referrals and making sure there's structures in place to follow in that situation. Yeah. And then Rosalind, who's a nurse in the Solomon Islands, has also written, consider the wound might be infected, ask about diet, and consider it, and ask if the medication has been taken properly or not.
That. And look, they're all everybody's made really good points. Everybody's got really good thought process around this, and many of you have got, if not all of you, have got really good structured approach to how you manage people who are very high. Any other questions, Daniel?
I think that's all the comments from the chat. I'm not sure. Yeah. In
your feedback, everyone, please don't hesitate to put down other things that you'd like more detail on. You know, we can do a variety of things, but if you'd like more detail on a narrow range of topics, don't hesitate. This is very broad today, but we can actually narrow it down and talk much more specifically about things if that would be helpful.
Hi, and sorry, I just have a question. It's not a question actually.
Yeah.
This morning, early in the morning, I was reading through and I came across this injection, semaglutide injection.
Yeah, very good. Yeah.
Which is given once a week for diabetic patients. But sorry, I haven't able to read through it. I know for sure we don't have it in Fiji, but this injection is given to diabetic patients once a week.
Yes, it is.
And I have also there was some also stated that they are also using this injection to lose weight, if I'm not wrong.
Yep, absolutely. So for everyone's benefit, this is exactly what it is, and it's approved for use in people with diabetes in this country. The way it works is that it's in the class of drugs called GLP-1. And simplistically, the way it works is that it actually does a number of things. Because of the way it works, it actually delays gastric emptying, and it then means that people get early satiety, so they feel full on a very small meal, and they lose weight because of that. And physiologically, what it does is it inhibits the production of new glucose by the liver, it inhibits the production of glucagon, and it relies on insulin availability to basically then, because that insulin becomes more sensitized, it then works more effectively. And because then people lose weight, it's once a week. It's a very comfortable injection. The device is really easy to use. It's got incredibly good statistics with it. There are 3 doses, so that you'd start on the 0.25 milligram dose once a week, and you do that for 1 month. Then you go up to the 0.5 milligram for 1 month, and then you increase it to the maximum dose of 1 month. And it's important to titrate it that way so that people then have minimal, if no, side effects. Actually, they tolerate that process well, and it's incredibly effective. If you can at all get your government or your health department to subsidise it or to provide it to people with diabetes in your care, it will dramatically change their management. We use it a lot in this country for First Nations people, particularly where they're living very, very remotely and they don't have access to regular healthcare. And it works very well in those populations where their diabetes is high prevalence in this country in First Nations people. And so it's a great drug to use because it is once a week and it doesn't hurt.
I might go over it because I haven't read through it. It kind of fascinated me.
Yeah.
It's really amazing what we are getting now.
Oh, it is. It's incredible. I mean, there are 2 drugs approved in this country. One is semaglutide, and that's Ozempic as a brand name in this country, made by Novo Nordisk. And the other one is called Trulicity. It's in TRULIC. And it is called dulaglutide. So DULAG. And I'll try and send it to Daniel, and he can send it around. So there are 2
yes, please, that would be lovely.
Yeah, 2 medications approved in this country. So it's dulaglutide and called Trulicity, and the other one is, as you said, the semaglutide or Ozempic. Eli Lilly make the Trulicity, and Novo Nordisk make the Ozempic.
Okay, thank you.
But do read it up, because if any of your departments of health, or any of you in a clinical sense, can encourage your health departments to bring it into the country, it will make a big difference to your people, particularly those with very remote communities like you do in PNG. It's once a week it makes it much easier to manage when it doesn't, it can be much more easily made accessible, because of it will just be once a week.
Interesting.
Any other questions, folks?
Thanks, Shada, and Alfred's just raised in the chat the importance of checking the sound side of an amputee to see red flags such as wounds, as well as obviously checking the amputated side. So thank you, Alfred.
Yeah, absolutely, I agree, Alfred. Thank you.
If there aren't any more questions, I'll just repeat what I said earlier. Feel free to send the questions through by email to myself after the session, and I'll send them on to Anne to answer. Thank you for everyone who's contributed to the session. It's been really great to hear your thoughts and your questions and your feedback. As Anne mentioned, this session's obviously been quite broad on diabetes, and I think the next session we're planning to run next month will be a little bit more looking at lifestyle modifications, diabetes education, but it can be formulated around what people want to hear more about as well. Like Anne said, we can get a lot more specific on certain topics if that's what people want to hear about. So please just let us know.
There's nothing off the agenda, so it doesn't matter, just one topic. We can talk about just one thing, or we can make it as broad if that's more useful to you. So make sure that you put in comments that are going to mean that we develop a presentation that really makes it relevant to what you want to know. Don't hesitate.
And I will send out a feedback form for everyone to fill in, so you can provide that feedback after the session. All right, and we've just got the review of the expected outcomes. I think that's it for today.
Well, hopefully everybody, we've achieved those goals and the outcomes that we set up for you today. And I hope you found the presentation and the post discussion useful, and that it met your needs. But please don't hesitate to ask more questions. If you were too shy to ask, there are no wrong questions, and there are no silly questions. It's really important that we fill the need for you so that you get benefit from these sessions as we put them together.
Thank you, Anne. On behalf of everyone, a massive thanks for you today and for delivering the session. I know I learned a lot, and I'm sure everyone else learned something as well. And thank you all for coming and your time today. Hopefully you found it valuable. And like we've already mentioned, any feedback on the sessions and how we can improve it to make it more beneficial is very, very welcome, as well as any extra questions that you have for Anne as well. So thank you all.
I'm actually, Just Daniel, I'm writing in the chat those 2 drugs.
Okay.
Glutathione. There we go. So I've written both those drugs in the chat, everyone. Okay.
I'll send those out in the email with the feedback forms as well. And thank
No
you.
worries. No
Thanks
worries.
everyone.
Thanks for coming along, and
Thank you, Anne,
I'll talk to you soon.
thank you, Anne, and thank you, Daniel.
Thank you. Thanks,
And
everyone.
motivational
Thank
team.
you.
Thank you. Bye.
Bye. Bye.
Thanks guys.
Thank you. Bye.
Thank you.
Thank you. Bye, everyone. Bye.
Thank you. Bye.
They all gone?